So I am Marie Bernard. I'm the Deputy Director of the National Institute on Aging at the National Institutes of Health, but I also wear another hat. I'm co-chair of the Trans NIH and Inclusion Governance Committee. This is a committee that oversees for all of NIH how well we are adhering to policies for inclusion of women, underrepresented minorities, and heretofore children in clinical studies. And very recently, we've had a change in our mandate to also take into consideration the inclusion of older adults. So I'm to talk about barriers, but I'm also going to talk about things that we have done to try to remove some of those barriers. So how did all of this come about? There was something called the 21st Century Cures Act that was passed by Congress in 2016. It was a pretty all-encompassing bit of legislation that had impact on multiple federal agencies, including the National Institutes of Health. And one of its provisions was for NIH to consider inclusion of individuals in clinical studies based upon age. This was, quite honestly, very much motivated by strong lobbying by scientists and advocates in the pediatrics world who felt that the reporting of children in clinical studies was inadequate. And as Congress tends to do, they consulted with NIH for technical assistance to get a sense of what the impact of the proposed legislation would be. And when they consulted with us, we were able to say that we saw a problem with inclusion on both ends of the age spectrum, and that we would prefer to do a scientific workshop to take a look at what the barriers and opportunities were. So when the law was passed in December 2016, it mandated that workshop that we were already thinking about, that it take place within 180 days. And then within 180 days of that, for us to revisit our policy with regards to inclusion and reporting by age. So what were the data that led us to make that response when we were consulted for technical assistance? The Inclusion Governance Committee had already been considering, how adequately were children being included, and wanted to know how adequately were older adults being included. And thus, we had a trans NIH portfolio analysis done of phase 3 clinical trials registered in clinicaltrials.gov and funded by NIH through to 2015. We focused on phase 3 clinical trials because, of course, these are theoretically trials that are large, that are checking effectiveness as well as efficacy, and the data are theoretically ready to be generally disseminated. Thus, you would expect a fairly representative population included in those trials. The analysis focused on top 10 causes of hospitalization or diseases that affected disability-adjusted life years for older adults. And it included an assessment of the mean age of people involved in the studies, age ranges, inclusion and exclusion criteria, and age requirements for the studies. So this is what was found. You see that there were a generous number of studies found for all 10 of the conditions. And when you look at the right-hand corner, anyone who's familiar with the older adult population, the mean ages skew rather young for these conditions. In fact, when we compared the mean ages for the conditions versus what the literature showed to be the mean age of the manifestation of these illnesses, the only one that came close to matching what was the case for the general population was prostate cancer. And even with that, it's somewhat young. And even when further analysis was done to see how many of the studies were prevention trials versus intervention trials, that did not mitigate the skewing to the younger population. So we concluded that based on age, participants in trials may not represent real-world populations with these diseases of older adults. And in fact, older adults were often excluded altogether. Some 27% of the studies appeared to have arbitrary upper age caps. In addition, there were often other factors that would implicitly or indirectly exclude older adults, such as excluding inclusion based upon common conditions found in older adults like hypertension or diabetes or polypharmacy. Elaborating further, we know that some 65% of people 60 and older have hypertension. About 21% of people 65 and older have diagnosed diabetes. And of those people who are 65 and older, there's a mean intake of about 4 medications. About 40% of the population takes 5 or more medications. And yet this is what was found when you looked at, again, the 10 diseases and conditions of focus and how frequently people were excluded based upon taking multiple medications, having hypertension, or having diabetes. Very specifically for the polypharmacy, as few as 12% to as many as 42% of studies excluded individuals who are on multiple medications. As few as 4%, but as many as 32% of studies excluded individuals based on having high blood pressure. And as few as 4%, but as many as 33% of studies excluded people based upon having diabetes, causing potentially exclusion of older adults. So with those data in hand, we did move forward in developing a workshop, Inclusion Across the Lifespan, which Dr. Appleby referenced in his opening comments. It was held June 1st to 2nd in 2017 when we were able to gather in person, 2 weeks short of the 180-day deadline. And you see in the picture, Dr. Francis Collins in the far right corner at the podium charging the group. We had a very esteemed group of scientists to come together and help us to think about the challenges and barriers to including children and older adults in clinical research, and to think about strategies that would produce more age-inclusive clinical studies. And the output from that workshop, as well as lots of other input and lots of deliberations across NIH, led in December of 2017 to this announcement of a new policy. It was basically a revision of what had been the inclusion of children policy. It was retitled Inclusion Across the Lifespan. And very specifically, it stated that as of clinical studies that were submitted to NIH for January 2019 and beyond, it was expected that all applications would submit a plan for including individuals across the lifespan. And if for any reason people are going to be excluded based upon age, a rationale and a justification needed to be provided for the age range that was proposed. It's recognized that scientifically it may not be appropriate, for instance, to plan to do an Alzheimer's study in children or a measles study in older adults, but it needs to be justified. And scientific review groups have been very good about this. I've been really edified when I've seen some restatements from proposals that have come through since January of 2019 to see them criticizing applications because there was not that consideration and scoring them accordingly. Additionally, this policy requires in progress reports for any project that was submitted January 2019 onwards to provide anonymized individual level data, not only about age and enrollment, but sex, gender, race, and or ethnicity, which will allow us, NIH, to be able to look at what's going on with our clinical studies in a much more granular fashion than has been the case heretofore. Quite honestly, for that trans-NIH portfolio analysis that I mentioned, it was very difficult to conduct just looking at progress reports from grants because the data were reported in a variety of ways, often in aggregates, and it was difficult to tell who was truly included in the studies based upon age, leading to a lot of work by our staff going through all of those clinical trials to find the publications that were associated with them to better understand. And as you see in the bottom right-hand corner, the units that can be used, since this is for children and older adults, can be anything from hours to years. So the policy has been in place for a year and a half now, and we have decided that we will have a follow-up to the initial Inclusion Across the Lifespan workshop that will be taking place a little less than a month from now. Its registration is open through September 1st, so hopefully this workshop will provide you an appetite for thinking even further about inclusion of older adults. The intent of this this workshop is to provide evidence-based practical advice to scientists to allow them to meet the spirit as well as the letter of the policy. There's no question scientists can simply say that they do not have an upper age limit and they don't have a lower age limit, and yet not meaningfully include older adults and children. The intent of this study is to help those scientists who aren't familiar with or comfortable with that recruitment to think about appropriate recruitment policies, inclusion and exclusion criteria, to think more creatively about how their study design should be configured, how their analyses would be done to allow the appropriate inclusion of all groups. And we say across the lifespan, there will be focus on underrepresented minority groups, women, people in rural and isolated settings, and others who are not typically well represented in clinical studies. So we would encourage you, if this has whet your appetite, to consider participating in that workshop as well. Thank you.